Welcome back. In this second block, we'll briefly review the older cytotoxic agents that are still used. We already talked briefly about the cell cycle, and the cell cycle is probably a more important parameter to consider with these older cytotoxic agents because many of them are pretty specific about targeting cells, no matter what they are, at a certain point of division. This graphic, and no need to really focus on the details of this, but this graphic will demonstrate for you a sort of depiction of which agents are more specific for certain points in the cell cycle and cell division. So for example, the antimetabolites like methotrexate are effective in the S phase. The topoisomerase inhibitors are in G2, whereas the enzymes are more specific in G1. And then the Vinc alkaloids in the metaphase and the like. So there are a number of agents that, in the names of these drugs may be more or less familiar to you, and that's probably not critical at this juncture. But the older cytotoxic agents really might be quite specific related to where they are going to be most effective in cell cycle, cell replication. The older cytotoxic agents are often broken down into different ways. One is by their class. The older alkylating agents, the antimetabolites, the anti-tumor antibiotics, the mitotic inhibitors, the topoisomerase inhibitors, and then a group of miscellaneous agents. Again, these agents are still used in practice, used maybe less so than we used to, but there are some that are still pretty commonly used in regimens, and we'll talk a bit about those specific situations when we come to them. So the alkylating agents, the older group of drugs are the nitrogen mustards here, which include ifosfamide, chlorambucil. These were older therapies that were used in certain situations that they still are used, but much less so than they used to be. And also other alkylating agents, including the older busulfan as well. Agents that are like the alkylating agents include the nitrous ureas and sort of other therapies, but the one group so far of the cytotoxic chemotherapeutic agents that are still widely used are the platins, the platinum drugs that are sort of midway through this screen. These, the carboplatin, cisplatin, and oxaliplatin, are still fairly commonly used in combination regimens for cytotoxic agents. And we'll talk more about these, but they're really particularly problematic for causing kidney toxicity, acute kidney injury, and some neuropathies and neurologic complications as well. They're also pretty emetogenic, meaning they cause a high degree of emesis. And so we're pretty aggressive at managing, preventing chemotherapy-induced nausea, vomiting when we use them. And we also want to make sure the patient's well hydrated to avoid acute kidney injury when we use these. More on that in the toxicity management block in a bit. The purine analogs occasionally still used for certain types of cancers. The pyrimidine analogs, again, fluorouracil specifically, gemcitabine, still sometimes used in a number of regimens as well. The antimetabolites, you probably will or soon to recognize methotrexate and hydroxyurea. We also use these agents to interfere with other pretty much autoimmune kinds of conditions, rheumatoid arthritis, for example, and sometimes in some other autoimmune conditions as well. The doses used in cancer therapy are often quite a bit higher. The anti-tumor antibiotics, the anthracyclines in particular, these agents have a high degree of cardiac toxicity, meaning that folks who get cumulative doses of these agents, daunorubicin, doxorubicin, these agents are associated with causing higher risks of potential down the line, months or years later, for serious cardiovascular compromise and folks developing heart failure, cardiomyopathies. And so we're really careful about that. The other thing with these agents is that they're highly irritant to the vein. So they're very problematic in administering them. And like many of the other cytotoxic agents, have a pretty significant degree of bone marrow suppression. We'll talk about that as well. So the anthracyclines, when you think about, doxorubicin and daunorubicin, among the other things you'll notice about it if you're familiar with these drugs, is that they are bright cherry red in color. And so just the color of the drug infusing is sometimes quite uh, uh, almost psychologically having an impact on the patient, just the color of it. And it has a little nickname. It's called, in some circles, called the Red Death. Um, but it is highly effective for certain types of cancers and are still used. We just have to watch for cardiac toxicity, extravasation risk, and bone marrow suppression. Sort of other specific agents might have a role in certain subsets of conditions. Bleomycin, for example, could be used for certain subtypes of cancers, and also because it's a pulmonary irritant that is sometimes used for a beneficial as well as being careful of its toxic effect. And mitomycin, sometimes used specifically for localized administration, for example, for certain eye cancers or certain other kind of situations given ophthalmologically. The vinca alkaloids are mitotic inhibitors, and they are used for a fair number of cancers still in combination. They do, however, cause a significant amount of peripheral neuropathies. And the taxanes historically, paclitaxel, docetaxel, have historically been used widely for breast cancers, among other things, with some reasonable good data historically for that. Their role sort of evolving in combination with other therapies. Other areas are the topoisomerase inhibitors, irinotecan, topotecan, etoposide. These are pretty highly, at least irinotecan is a pretty highly emetogenic agent. Bone marrow suppression with these agents as well. And then the miscellaneous drugs listed height here at the bottom, asparaginase, pegasparaginase, pretty limited in where sort of their role will be in certain cancers. We'll talk more about the other many toxicities of these cancers in the next block. We're almost actually done with this block, interestingly, because that's kind of where you have a picture of how things work. But the thing you have to consider is that the very drugs we use to treat cancers themselves are very caustic and problematic drugs. They themselves can cause mutagenicity, teratogenicity, carcinogenicity. They are directly caustic when they're touched. They can be vesicants to vessels or skin tissue. And so as such, they're pretty dangerous drugs to work with. And so there are guidelines and regulations that have developed called the USP 800 that's really, as of late 2020 and into 2021, are really being rolled out in the healthcare organization around the country, that they have adequate safeguards in place for when these drugs are ever used in healthcare. So the USP 800, the USP is the United States Pharmacopoeia. It's a nonprofit organization that looks at standards around safe pharmaceuticals and purity. They, in conjunction with the National Institute of Occupational Safety and Health, have identified which drugs are, they can be some of the drugs we've listed here and other drugs that are not listed here that are problematic in carcinogenicity, teratogenicity, any other reproductive toxicity, organ toxicity, or any other kind of problems that are associated with these toxic agents. And then they have developed a set of requirements and guidelines about how do you, if anybody's using them, how they're trained, procedures for how to transport them, to store them, to clean up after them, to decontaminate, to control if there's a spill, to document who's had these standards, and that anyone who's involved in healthcare needs to kind of be aware that these drugs could be problematic. For women of childbearing age, you work in healthcare, you generally want to even more so limit your exposure to some of these drugs because of their risks and want to be aware of them. So if you're working in a healthcare center that is having exposure to these particular agents, anyone wants to be concerned about, how are you safeguarded for that exposure, particularly if you're a woman of childbearing age, and particularly if you're a woman who's pregnant or trying to become pregnant. This is even more sort of pivotal to your understanding. Okay, so that's in a nutshell the cytotoxic agents overview.